Let's discuss an Endocrine Society guideline on hyperprolactinemia. So, this is a guideline and it is released by the Endocrine Society. And although this guideline was released in 2011, but it has not been updated after that, and it is something very important because a lot of things regarding hyperprolactinemia, how to manage, how to diagnose, what is macroprolactinemia, causes of hyperprolactinemia, how to manage a patient with hyperprolactinemia or prolactinomas in pregnancy, all these are given in this guideline. So that's why I have chosen this guideline to discuss. So coming on to first thing, the diagnosis of hyperprolactinemia, what the guideline says about that, how to diagnose hyperprolactinemia. The thing is, the guideline says only a single measurement of serum prolactin is required. There is no need to do the dynamic testing of prolactin because prolactin is not secreted in a dynamic way. So just a single measurement is enough. And what about the levels? A prolactin level greater than 500 microgram per liter is diagnostic of macroprolactinemia. Although a prolactin level greater than 250 microgram per liter usually indicates presence of prolactinoma, which can be a microprolactinoma also. And selected drugs like risperidone, metoclopramide, all these can also lead to hyperprolactinemia. But usually the ranges are below 200, but sometimes they can go above 200 microgram per liter. But anytime if we are getting it more than 500 microgram per liter, it is highly diagnostic of macroprolactinoma. Macroprolactinoma means the tumor size is more than 10 mm. And when to take the serum prolactin? It can be drawn any time during the day, provided we avoid excessive venipunctures, because any stress can lead to increase in prolactin levels. What is macroprolactinemia? Macroprolactinemia is something which is diagnosed, which is suspected in a patient who is asymptomatic. An asymptomatic hyperprolactinemia, there is a possibility that it can be because of macroprolactin. There is a difference between macroprolactinemia and macroprolactinoma. Okay, so macroprolactinemia means there are different kinds of prolactin which are there in our serum. The normal prolactin which runs in our serum is the monomeric prolactin, but sometimes the prolactin molecules, they held up together, so they become big prolactin or big prolactin. So when multiple prolactin molecules, they stick together, that forms the macroprolactinemia. It is different from macroprolactinoma, which is most likely a tumor which is there in the pituitary gland. Macroprolactinemia is just a macroprolactin which is running in the serum of the patient. So what to do now with this macroprolactinemia? Because it is asymptomatic and it is harmless. So 85% of circulating prolactin is monomeric, as I told. And serum also contains covalently bound dimer big prolactin and big prolactin. Usually these big prolactin, they are harmless and they are not bioactive. Only monomeric prolactin is bioactive. So macroprolactinemia denotes a situation in which a preponderance of circulating prolactin consists of these larger molecules. The larger prolactin forms, that is macroprolactin, is less bioactive, and macroprolactinemia should be suspected when typical symptoms of hyperprolactinemia are absent. And what to do if such thing happen? Polyethylene glycol precipitation is an inexpensive way to detect presence of macroprolactin in the serum. Now coming on to the causes of hyperprolactinemia. The first and foremost cause which we have to rule out is physiological causes. It can increase as a result of coitus, exercise, lactation, pregnancy, sleep and stress. So all these things firstly we have to rule out. Second most important thing is the pathological causes lead because of hypothalamo-pituitary stalk damage, which is known as stalk effect. Any granulomas, infiltration, irradiation, or Rathke pouch cyst, any trauma or tumor, which can be craniopharyngiomas most commonly, these all can lead to the stalk compression, and as a result, the dopamine which is being released from the hypothalamus will not be able to reach the pituitary. So uninhibited release of prolactin will happen. So the dopamine has an inhibitory effect on prolactin. It keeps check on prolactin so that it does not release much. But whenever there is this stalk compression happens, the dopamine is not able to reach to the pituitary, thus leading to the increased release of prolactin. So that is the cause of hyperprolactinemia in such tumors. Then coming on to the pituitary causes. The very important cause is acromegaly. So all the patients should be screened for acromegaly because the growth hormones, 50% of the cases it happens, the growth hormone secreting tumors or growth hormone hyperplasia, they will lead to hyperprolactinemia. So such patients should be screened for acromegaly. And then there can be idiopathic causes: macroadenoma, macroprolactinoma, prolactinoma, surgery and trauma. These things are very important. Other causes of hyperprolactinemia include the systemic disorders, which include any chest trauma, surgery or herpes zoster, chronic renal failure, cirrhosis, cranial radiation, epileptic seizures, polycystic ovarian disease, which is a common reason for hyperprolactinemia. Another important cause is the pharmacological agents, out of which the neuroleptics and antipsychotics are most commonly implicated reason. Coming on to why CKD leads to hyperprolactinemia. So what happens is, in about 1/3 of the patients with kidney disease, hyperprolactinemia develops because of decreased clearance and enhanced production of the hormone. The important thing is, dialysis does not alter serum levels, but prolactin levels normalize after renal transplantation, and menses may return after bromocriptine therapy. Acromegaly is another thing associated with hyperprolactinemia, and it is seen in up to 50% of the patients with growth hormone secreting tumors can have hyperprolactinemia. What is idiopathic hyperprolactinemia? When the cause could not be found. It is seen that in 10% of the patients with idiopathic hyperprolactinemia, they harbor a microadenoma, and progression from a microadenoma to a macroadenoma is a rare event. Spontaneous normalization of the prolactin levels occur in approximately 30% of the patients with idiopathic hyperprolactinemia. Coming on to drug-induced hyperprolactinemia, some medications are implicated in having increased prolactin levels. So what guidelines suggest is to discontinue the medication for 3 days and remeasure the serum prolactin. If they come to be normal, it means the hyperprolactinemia was because of the medication. Neuroleptics and antipsychotics are most common cause of the drug-induced hyperprolactinemia. Usually the levels of prolactin range between 25 to 100 microgram per liter, but some medications like metoclopramide, risperidone and phenothiazines, they can lead to increased prolactin more than 200 microgram per liter. So what are the causes which are involved? The mechanism is dopamine antagonist effect of these medications. So this can happen because of the medications are inhibiting the dopamine effect. Drug-induced hyperprolactinemia treatment. So what guidelines suggest is that the patients who are asymptomatic with hyperprolactinemia, they should not be treated. There is no need to treat them. Just on the basis of that, the serum prolactin is more than what is considered as normal. But if patient is showing some hypogonadal symptoms or the bone mass density has been reduced, then estrogen or testosterone supplementation should be done instead of the dopamine agonist therapy. Coming on to the management of hyperprolactinemia. So guidelines suggest that the cabergoline is the most preferred dopamine agonist. Why? Because it is more efficacious and it has higher potency in decreasing the tumor size. Usually it cannot be said why cabergoline is so much effective than bromocriptine, but most commonly what has hypothesized is it has higher affinity for dopamine receptor binding sites. Bromocriptine decreases the pituitary tumor size by 50% in 2/3 of the patient, while cabergoline does it in 90% of the patients. How to follow up the patient on dopamine agonist therapy? We cannot just leave the patient putting on dopamine agonist. We have to do the proper follow-up. So the first follow-up is 1 month after the therapy. So we have to do the periodic prolactin measurements. The first measurement is done first month after the therapy, and then accordingly depending on the levels. Second thing is we have to repeat the MRI in 1 year in patients with microadenoma, but in patients with macroprolactinoma we have to do it in 3 months, or if the patient has new symptoms like galactorrhea, visual symptoms or headaches, then we have to repeat more frequently. But in asymptomatic patients, annually we have to repeat it. Then visual field examinations we have to do, and we have to check for the hypogonadal symptoms like steroid dependent bone loss, persistent galactorrhea in face of normalized prolactin levels. All these things we have to follow up in the patient on dopamine agonist therapy. Coming on to microprolactinomas. So the microprolactinomas, the guidelines say we should not treat asymptomatic patients with microprolactinomas with dopamine agonist. So they suggest that the treatment with dopamine agonist or oral contraceptive in patients with amenorrhea caused by microadenoma. In case the amenorrhea happens, then either dopamine agonist or oral contraceptives can be given. But if the patient is asymptomatic, just because microprolactinoma is present, there is no need to treat. Patients treated with oral contraceptives and estrogen progesterone replacement for 2 years have not shown to increase in tumor size. So specifically this has been mentioned because sometimes it is anticipated that the giving oral contraceptives, because they have estrogen, that might lead to the growth of the tumor, but it is not seen. Even after 2 years of giving the oral contraceptives, the growth of the tumor has not been seen. Now, when to withdraw the dopamine agonist? So the dopamine agonist should be given for 2 years. After that, they can be withdrawn if patient has there is no visible tumor or the serum prolactin levels have been normalized. Then the dopamine agonist can be withdrawn after 2 years. And how the patient should be followed up post withdrawal? The patient has to be followed up with measurement of serum prolactin every 3 months for first year, and then annually thereafter. MRI if prolactin increases above the normal levels. What is resistant prolactinoma? So in case of the guidelines recommend before labeling a patient as resistant prolactinoma, the dose has to be increased to maximum tolerable doses before referring the patient for surgery. And what this resistant prolactinoma is, if the patient fails to achieve a normal prolactin level on maximally tolerated doses of dopamine agonist. And secondly, if there is failure to restore fertility in patients receiving standard doses of dopamine agonist. In such situations, it is known as resistant prolactinoma. Microadenomas are usually less resistant, and men are more likely to be dopamine agonist resistant. The dose as high as 11 mg per week sometimes need to be given to overcome the resistance. But such a high doses can lead to cardiac valvular regurgitation. So that's why we have to monitor the patient with the ECGs and echocardiography. But the usual doses which we are giving in our clinics, that is 1 to 2 milligram per week, they do not lead to these cardiac valvular problems. So there is no need for the regular echocardiographic screening if we are giving the regular doses. Resistance versus intolerance. So we should not confuse resistance versus intolerance. Sometimes the patients are not able to tolerate the bromocriptine and cabergoline because they have got like side effects like nausea, vomiting. So intolerance is where the side effects of agonists preclude their use. That is different from the intolerance. Now, how to manage the resistant macroprolactinomas? Firstly, the option of transsphenoidal surgery is there. So that can be done, but it has its own problems. The side effects of the surgery are the hypopituitarism, diabetes insipidus, CSF leak, and local infection. What is malignant prolactinoma? A malignant prolactinoma is defined as one that exhibits its metastatic spread within or outside the central nervous system. It is very difficult to differentiate between carcinoma and adenoma, and there are currently no pathological markers whereby the malignant potential of a prolactinoma can be predicted. Management of malignant prolactinomas. The treatment of malignant tumors is difficult and survival is approximately about 1 year. Radiotherapy should be reserved for resistant or malignant prolactinomas. Radiation therapy has been associated with many side effects like hyperpituitarism and cranial nerve damage and secondary tumor formation. A drug known as temozolomide has come up for the treatment of malignant prolactinomas. How it works? It reduces the prolactin levels and controls the tumor growth if tumor specimens do not express methylguanine DNA methyltransferase. Control. Management of prolactinoma during pregnancy. So, during pregnancy, if patient has microadenoma, usually the dopamine agonist therapy needs not to be continued, it can be discontinued. But in selected patients with macroadenoma who become pregnant on dopaminergic therapy and who have not had prior surgical or radiation therapy, it may be prudent to continue dopamine therapy throughout the pregnancy, especially if the tumor is invasive or is abutting the optic chiasm. So in crux, if microadenoma is there, we can discontinue dopamine agonist. If macroadenoma is there and patient has no previous history of surgery or radiation therapy, we have to continue the dopamine therapy. Then what to continue? Bromocriptine or cabergoline? Out of these, bromocriptine is the preferable agent because there are a lot of studies which have been done on bromocriptine, and cabergoline also is good, but bromocriptine is the preferred agent. There is the agent quinagolide which should not be continued because of poor safety profile. So guidelines recommend the bromocriptine therapy in patients who experience symptomatic growth of prolactinoma during pregnancy. Continuous use of bromocriptine throughout pregnancy has been reported in approximately 100 patients. This treatment does not appear to be harmful, although there was one case report of undescended testes and one of talipes deformity. So both were non-lethal deformities which were reported with the bromocriptine in 100 patients. How to monitor the pregnancy? In pregnant patients with prolactinomas, the guidelines recommend against performing the serum prolactin. There is no need to perform serum prolactin during the pregnancy. Secondly, about the MRI. So guidelines recommend against the use of routine pituitary MRI unless and until patient has some visual symptoms or headaches. Any visual compromise if happens, then only we have to do the MRI. So routine use of MRI in patients with macroadenoma or even in intracellular macroadenomas is not needed. But yes, if patients present with clinical evidence of tumor growth like headaches, visual field compromise, we have to do it. Pregnant patients with microadenomas may be followed by just clinical examination during each trimester. There is no need of serum prolactin, there is no need of MRI. in those patients who have undergone debulking pituitary surgery or pituitary irradiation before pregnancy, the risk of symptomatic growth is only 2.8%. They are talking about macroadenomas. But in patients with macroadenomas who did not undergo surgery or irradiation before pregnancy, the risk of symptomatic pituitary tumor enlargement was 31%. So in such patients, the MRI might need to be done if they have some visual field problems or if they present with headaches. The onset of new or worsening headache or change in vision or both mandates the urgent performance of visual field testing and pituitary MRI without the use of gadolinium. So this point is important. Gadolinium we should not use, and plain MRI has to be done in pregnancy. So thank you everyone, and I hope this was useful, and we will come again with another set of guidelines and more informative sessions on the topics related to reproductive medicine. Thank you.